Hello everyone, welcome back to Scrubs and Notes. I'm Raymond, and today we are tackling a fascinating but dangerous topic, tetanus, often known as lockjaw. This acute life-threatening neurologic syndrome is entirely preventable, yet still causes significant mortality worldwide. By the end of this video, you will have a clear understanding of its microbiology, the deadly journey of its neurotoxin, its diverse clinical presentations, and most importantly, how to diagnose, manage, and prevent it to protect your future patients. So let's dive in. Let's start with the basics. Tetanus is caused by a potent neurotoxin called tetanospasmin, produced by the bacterium Clostridium tetani. This organism is a gram-positive, obligate anaerobic motile bacillus. Now, the really important thing about Clostridium tetani are its spores. In unfavorable conditions, this bacterium forms incredibly hard terminal spores, giving it that characteristic drumstick or tennis racket appearance under the microscope. These spores are remarkably resistant to heat, drying, and most disinfectants, and they are found almost everywhere, in soil, dust, and even in the guts of animals and humans. The key takeaway here is that the spores themselves are harmless. Disease only occurs when these spores are introduced into a wound that provides an anaerobic environment, essentially, an oxygen-free zone where they can germinate into their active form. Think deep puncture wounds, devitalized or necrotic tissue from crash injuries or burns, or wounds contaminated with foreign bodies like soil. Co-infection with other bacteria that consume local oxygen can also help create this anaerobic environment. The entire devastating clinical picture of tetanus is due to one thing, the neurotoxin tetanospasmin. Once the spores germinate in that anaerobic wound, the active Clostridium tetani bacilli start producing this toxin. Here is its sinister journey and mechanism of action. Tetanospasmin is released from the bacteria right there in the wound. It then binds to the presynaptic nerve terminals of alpha motor neurons at the neuromuscular junction. Once bound, the toxin is internalized and undergoes retrograde axonal transport. This means it travels backwards along the axon all the way up to the motor neuron cell body in the spinal cord and brainstem. When the toxin reaches the motor neuron cell body, it's released into the synapse and then taken up by the presynaptic terminals of adjacent inhibitory interneurons, especially something called Renshaw cells. Tetanospasmin is a zinc-dependent enzyme that targets a protein called synaptobrevin 2. Synaptobrevin is absolutely essential for the release of neurotransmitters from synaptic vesicles. By cleaving synaptobrevin, tetanospasmin irreversibly blocks the release of primary inhibitory neurotransmitters, that is glycine and gamma-aminobutyric acid. The result is disinhibition. Your alpha motor neurons are now freed from their normal inhibitory control. This leads to massive, unregulated nerve discharges, causing increased resting muscle tone and rigidity, simultaneous and sustained contraction of both agonist and antagonist muscles, that is, imagine your bicep and tricep contracting at the same time. Then exaggerated responses to the smallest sensory stimuli, triggering violent, generalized reflex spasms. The toxin can also spread to the sympathetic nervous system, leading to dangerous autonomic dysfunction. The incubation period from injury to first symptom is typically 3 to 21 days, averaging 7 to 10 days. The period of onset from the first symptom to the first generalized spasm is usually 24 to 72 hours. A crucial prognostic indicator is a shorter incubation period of less than 7 days and shorter periods of onset of less than 48 hours mean more severe disease and a poorer prognosis. Now let's look at the different forms of tetanus. Therefore, we have generalized tetanus, neonatal tetanus, localized tetanus, and cephalic tetanus. Generalized tetanus is the most common form, accounting for over 80% of cases, and it's also the most severe. Classically presents with a descending pattern of muscle rigidity. Trismus, this is often the very first sign. It's a painful spasm of the masseter muscles, making it difficult or impossible to open the mouth. Risus Sardonicus, a truly characteristic fixed sneering or grinning facial expression due to sustained contraction of facial muscles. Progressive rigidity, this spreads downwards, affecting the neck, causing difficulty swallowing and leading to body-like chest and abdominal muscles. Opisthotonus, a dramatic and excruciating posture where the head, neck, and back are severely arched backwards due to powerful spasms of the paraspinal extensor muscles. Reflex spasms, these are the hallmarks of severe tetanus. They are intensely painful, violent, convulsive contractions of muscle groups. What makes them chilling is that they can be triggered by the slightest external stimuli, that is a light touch, a loud noise, or even a draft of air. And throughout these horrifying spasms, the patient remains fully conscious. Complications can be severe, including laryngeal spasm leading to airway obstruction, fractures, tendon avulsions, and rhabdomyolysis. Autonomic instability is a late but major cause of death, usually appearing in the second week. It's due to the toxin disinhibiting the sympathetic nervous system. You will see widely fluctuating blood pressure, that is labile hypertension and tachycardia, followed by profound bradycardia and hypotension. Then profuse sweating, fever, and cardiac arrhythmias. Neonatal tetanus is a tragic form of generalized tetanus in newborns, usually between 3 and 14 days of life. It's a direct result of umbilical stump infection, often from unhygienic practices like applying soil or dung, or using unsterile instruments in babies born to unimmunized mothers. The first sign is often a subtle inability to suckle or breastfeed, quickly followed by irritability, excessive crying, then rapid onset of generalized rigidity and spasms. The mortality rate is extremely high. Localized tetanus is uncommon, presenting as persistent, painful rigidity confined to the muscles near the site of injury. It can last weeks and sometimes progresses to the generalized form. Cephalic tetanus is rare, associated with head or neck wounds or chronic ear infections. It is characterized by flaccid pulses of one or more cranial nerves, often the facial nerve, in addition to trismus. Prognosis is poor as it frequently progresses to generalized tetanus. Diagnosing tetanus is entirely clinical. There are no confirmatory laboratory tests for tetanus itself. Your diagnosis relies on a compatible history. Always ask your patient about any potential wound, even minor, and especially vaccination history, combined with your physical examination findings such as Trismus, Risus Sardonicus, generalized rigidity, and those characteristic reflex spasms, all in a conscious patient. A useful bedside test is the spatula test. Gently touch the posterior pharyngeal wall with a sterile, soft-tipped instrument. Positive result, which is pathognomonic for tetanus, is an involuntary reflex contraction of the masseter muscles, making the patient bite down on the spatula. A normal gag reflex, where the patient tries to expel the spatula, is a negative result. Management of established tetanus is complex and requires admission to an intensive care unit or a dedicated quiet room. The goals are threefold: neutralize unbound toxin, eradicate the source of toxin, and control muscle spasms and provide supportive care. For neutralizing unbound toxin, give a single intramuscular dose of 3,000 to 5,000 units of human tetanus immunoglobulin. Crucially, TIG can only neutralize circulating toxin and toxin that hasn't yet entered the nervous system. It cannot cross the blood-brain barrier to affect toxin that is already bound to the nerve cell. Eradicate the source of toxin through thorough wound debridement. All potential wounds, even minor ones, must be identified, thoroughly cleaned, and surgically debrided to remove necrotic tissue and Clostridium tetani spores. Antibiotic therapy with metronidazole, 500 mg IV every 6 to 8 hours for 7 to 10 days is the drug of choice. It's preferred over penicillin G because penicillin is a GABA antagonist and could theoretically worsen spasms. Control muscle spasms and provide supportive care through sedation and spasm control using benzodiazepines. These are the first-line agents. They work by enhancing the effect of GABA at the GABA-A receptor, directly counteracting the loss of central inhibition caused by tetanospasmin. Diazepam is most common, often requiring very large continuous IV infusions. Midazolam or lorazepam are alternatives. Magnesium sulfate is often used as an adjunct. It has central sedative effects, helps reduce autonomic instability by blocking catecholamine release, and may have some neuromuscular blocking properties. Neuromuscular blockade is done in severe cases where spasms cannot be controlled and the patient develops respiratory compromise. You must paralyze, intubate, and mechanically ventilate the patient. Non-depolarizing agents like vaccination are used. Protecting the airway is paramount due to the risk of laryngeal spasms. Early elective intubation or even tracheostomy is often required. Management of autonomic dysfunction requires intensive monitoring. Labetalol, morphine, and magnesium are used to control the sympathetic hyperactivity. General supportive care includes minimizing all sensory stimuli by placing the patient in a dark, quiet room. Provide adequate nutritional support, often via NG tube or parenterally. Then prophylaxis for deep vein thrombosis and stress ulcers. Initiate active immunization. Clinical infection with tetanus does not confer immunity. The amount of tetanospasmin required to cause disease is far too small to be immunogenic. Therefore, All patients must begin a full primary course of tetanus toxoid vaccination upon diagnosis. The first dose should be given at a site separate from the TIG injection. Finally, prevention. This is the most effective public health strategy against tetanus, and that is vaccination. Active immunization during childhood. Pregnant women should receive tetanus toxoid during pregnancy, and this protects the mother and provides passive immunity to the newborn, crucially preventing neonatal tetanus. Booster doses are required every 10 years to maintain protective antibody levels. Post-exposure prophylaxis for wounds. This is how you manage a patient who comes in with a potentially contaminated wound. It depends on the wound type and the patient's vaccination history. Clean minor wounds and the patient's vaccination history is unknown or is less than 3 doses. Give TD or Tdap vaccine. And give TD or Tdap vaccine and tetanus immunoglobulin for all other wounds. For a clean minor wound and the patient's vaccination history is more than or equal to 3 doses, with the last dose being less than 5 years, no vaccine is needed. And the same for all other wounds. If a patient presents with a clean minor wound and their vaccination history is more than or equal to 3 doses, and the last dose being between 5 to 10 years ago, no vaccination is needed, but give TD or Tdap vaccine for all other wounds. And for a clean or minor wound, with a patient presenting with a vaccination history of more than or equal to 3 doses and the last dose being more than 10 years ago, give TD or Tdap vaccine and do the same for all other wounds. And that brings us to the end of our deep dive into tetanus, from the tenacious spores of Clostridium tetani and the devastating action of tetanospasmin, the distinct clinical forms, precise diagnosis, and the critical steps in management and prevention. You now have a comprehensive understanding of this important disease. Remember, prevention through vaccination is key, but knowing how to manage it in the clinic is equally vital. If this video helped you solidify your knowledge, please hit that like button, subscribe to Scrubs and Notes for more essential medical content, and share it with your fellow students. And let me know in the comments what internal medicine topic you want to tackle next. Thanks for watching, and I'll see you in the next video.